Thanks a lot.
Okay. Thank you both very much indeed. Thank you. So I'm very happy to take any question from the floor. Don't worry too much about Slido. We don't have a lot of time. If you feel more comfortable, do. But if you want to ask a question from the floor about anything that's been said, please do. I would like to make a kind of a bridge between the policy and what everybody has been saying. And I'm beginning to feel it's really interesting having conversations with all of you, because this call was, I don't know, AI and multiple long-term conditions, or multiple long-term conditions and AI. But when I talk to all of the collaboratives over time, this qualitative bit, the bit that's been really grounded at the beginning, we've learned so much in that process before we deploy any analytics. So there is a lot of output already there from this group. I'm just wondering, in light of the fact there isn't a policy unit for multiple long-term conditions, and certainly, and I'm sitting next to Simon, so I shouldn't really be saying this because it is life course very much that Melby are looking at. But for some of you who are working with communities that are, I don't like to say over 50 because I'm in that group, so I've lost the older group he was saying. But can we link in with you? Is there work that we're doing that can inform you? How can you learn from what we're doing and inform, Jane, the work that you're trying to do? How do we get research outputs that's already from this group into your policy work?
I mean, we're commissioned directly to answer questions of policy teams. So obviously, if any questions arise, and we work really closely with SRE. So by raising the profile of the outputs of this, and I know policy colleagues are already in the room, and there's one sat there who actually also works with us, Annie. And I would advise you to definitely work with SRE, the Science Research and Evidence teams. They're really well connected across the department. They know who the people you need to be sharing your evidence with. There's lots of ways that you can practically share it with. So it's not just running webinars, but actually meeting with policy teams, talking to them about your work, the things that you've found, really helps you then define the so what, so that you can start to frame your work and your outputs in really meaningful ways. And that's what's really important. I know I whizzed through the side, but actually understanding the policy need is so critical. And I think there is a real appetite. There's obviously an acknowledgement that this needs to be addressed, and we need all the work that's come out of this whole program. But again, it's just working with the policy teams to understand what their priorities are, so you can help frame your work in a way that's meaningful to them, that then they can make the best use of it when they're developing new policies.
Thank you for that. And Hajira and Simon, and I'm sure others of you that have been working on, we've talked about code lists this morning, but they've all been very medically orientated. I mean, Hajira, you must have been working on code lists in the same way that Simon has. I mean, how difficult was that to do? And what is the legacy for the learning that both of you have had, and others of you working with the non-medical code lists as such?
It was very difficult. It took a lot of time. We had a lot of extensions from the cluster aim study, and it required a lot of patient input and a lot of clinical input, because most of the codes aren't used. So as a GP, I very rarely will code emotion. For example, Simon mentioned emotion. So a lot of these codes are just redundant and not used. If we want to change things, government level has to introduce recording and coding specific to social care, the same way that we have cough markers that I have to go down and fill out a blood pressure and fill out a cholesterol. They need to ask me to do that with social care if they want to change things. That's what needs to happen.
And did you tap into any local authority data in the
Yes, and we use social care data too. Although I'm very critical, I'm allowed to say this because I'm a GP, but we're very critical of ourselves. Actually, GP records are amazing compared to many other specialities, compared to data around the world. We looked at data from Canada, America. Our electronic health records for primary care are pretty impressive. Even if we bring in social care records and local authority data, they don't compare in terms of the coding.
Yeah, it's very interesting. I work as a non-exec with an ICB, and we're trying to integrate local authority data, and it's the paucity quality. It's a little bit further behind than we are, so we shouldn't beat ourselves up. Simon, any comment there?
I think the other thing to say is that we talk a lot about coding, and for those not familiar with it, you know, coding is only part of the story of what is recorded in a consultation. There's not a free text that's recorded, and people are doing analyses on free text. That free text is much less available to us as researchers. But I also think that Lynn and I have talked about this in the wider PPI group in MELD-B. There is potential for patients themselves to start contributing information about themselves into their medical record. And we have this barrier between who, as Lynn questioned earlier, whose data is it? Whose records are they? And are there ways in which our AI learning can do more to record some of these other characteristics? Because it is a highly pressured environment to sit in general practice and try and get everything done that you're trying to do at the same time as putting the person in front of you first and foremost in your concern.
Yeah, it's very interesting to see it. Kathy had brought that into her equation when she was looking at data this morning about, how do we look at that quality data really? Somebody else who's worked in general practice, it's really, that's where the quality is of a lot of this data. Nuances of what we're talking about. I know Bruce has got his hand up over there, so I'm going to take a question from Bruce. And
yeah, it was really just that balance. So on the one hand, you could try and make me record stuff in the GP record, but benefits data, why don't you go to the benefits agency? You could make me record things about emotions, but I already write about them in free text. And so there's a balance between trying to, what do you think the right balance is between trying to get better, more and more coding versus going down the hellish path of trying to link to other data sets and then do NLP in free text?
I think that's very interesting. And I would actually perhaps pass that one over to Lynn, actually.
I get the utility of big data and whatever, but sometimes it's purpose. And actually, what's the purpose of what we're doing, and who has power over deciding what the purpose of what we're doing and what's important? Simon and I talked about this. Patients curate what they say. When I turn up to consultation, I've sifted, especially you're only allowed to talk about one thing. You curate what you say. So half the story is already lost. And then it's like Chinese whispers. Things are documented about me. Is that the most important thing I had to say? It's your interpretation, a clinician's interpretation. So I think if we want better data, then we need to involve people in actually capturing that data.
Absolutely.
Yeah.
Simon?
I'll just add to that. I think there is also potential for clever developments for capturing some of these things. I don't think we should say to GPs, do more, do it better, code more, code it better. But maybe systems can capture some of these things with some of the sort of innovations that we're considering in this group.
Yeah, I wonder how social media platforms and other kind of groups where people living with different conditions, how are we using or accessing?
As long as we don't mind that, because that's mined without people's permission.
Yeah.
Other people interpret
Yeah.
and analyze that. Sorry.
Yeah.
Well, that's a really interesting one, and I'm sure there's people in the room that know about sentiment analysis and how we actually do that. And it was really interesting during COVID. I'm going to just let you say the final word, Duleep. What have you learned by sort of your relationship with this community actually? And
so I think there are two things. One is lessons from this session are to involve people with lived experience or understand the lived experience at the outset, and probably also talk to policymakers. So if you want to influence policy, you may not be. You might be wanting to influence pharma or whatever. But if you want to influence policy, find out what's keeping Wes Streeting awake at night, and it's probably because the NHS is facing huge demand that's overwhelming supply, and actually we call it demand, but it's people with multiple conditions by and large that are in and out of hospital who needn't be there. And one of the things we can usefully do is work out, well, why are they there? Why are they ending up in hospital? I'll just give you one example of a really good way, a good form of intervention, which is British Red Cross run a whole load of high intensity use services for people who are in and out of A&E. And what they use care coordinators, don't use GPs, and GPs wouldn't have the time to do this. But what the care coordinators do is get to the root of why people are in and out of hospital. And often it has nothing to do with their health condition. It's something social that's escalating their health condition. It might be a toxic relationship at work. It might be a problem with the police. It might be something completely different, finance, debt, or whatever. that way you understand people's lives, and you need to be able to create the space in the system to understand the root causes, and then you design solutions around it. And that, I mean, we've got to find a way of capturing that data, because it can tell you who's going to be ending up in and out of hospital. But the solutions aren't always about data. They're about understanding people, and their lives are messy and complex and aren't just about clinical problems.
Absolutely. And I think Jara's point about bereavement as a trigger point is just a real example of that. So I'm glad to end up that Jane can go home and tell her husband she's not the only one who's actually trolling Wes Streetings at the moment. So Duleep, you're at it too, and we're all having a look at what's happening with the political eye at the moment, really, because I think it's so important to us. So can I just thank our panel very, very much indeed, all of you, for your contribution. Thank you.